All good things are three, so you won't be surprised if a third person now from UCLA comes to the stage representing nuclear medicine. I'm very happy to introduce to you Dr. Wolfgang Fendler, who is a visiting assistant professor at UCLA, and he's going to tell you what comes next after PRRT, the so-called PRRT 2.0.
Yeah, thank you very much, Ken, for the introduction. I'm very honored to be here in this meeting and also to take the discussion one step further from the present, rather more to the future. What could be future concepts in improving PRRT? And I will focus on 4 topics. What is the need for improvement currently? What are limitations of the current PRRT? What have we learned in Europe? What will be implemented in the US? Then the concept of somatostatin receptor antagonists as one of the key developments that might improve PRRT. And then I will show some clinical data on somatostatin receptor antagonists for imaging and for therapy, what has been published yet and which trials will roll on. And then, of course, I will make a summary of what could be future developments. So this is, again, just a simple scheme because I think it's important to understand on how to improve PRRT. A simple scheme of what we are aiming at for imaging neuroendocrine tumors or treating neuroendocrine tumors with PRRT. The tumor itself, to simplify it, to very much simplify it, consists of a huge amount of tumor cells that express this one target on their cell surface, so the somatostatin receptor. And we can target the somatostatin receptor of a neuroendocrine tumor cell using our ligands. So that's a medication, a drug that binds with a very high affinity. It will be given usually intravenously. It circulates through the blood, and by circulating, it will perfuse into the tumor tissue. It will bind on the tumor cells. It will bind to those receptors. It will stick there. And sticking there, as we have seen also in Dr. Herman's slide, is like a key to a lock, so it perfectly fits onto the receptor, and our key is radio labeled so we can use it for imaging or for performing treatment. So what are the limitations of this current concept, of the current ligands we use? So on the left side you will see one of the major limitations is that if we deliver below critical radiation dose to neuroendocrine tumor lesions or metastasis, and you see a patient example, you see an example of a patient who received an F-DOPA PET scan. That is a PET scan that exploits the properties of neuroendocrine tumors of producing hormones. And it can be performed in some European countries as clinical care, and you can see that the patient has midgut neuroendocrine tumor, lymph node metastasis, and diffuse liver metastasis that nicely take up this tracer and show here as dark spots. However, if dotatate PET is performed, so if you look at the somatostatin receptor, at our target that we want to treat, we see that a certain number of these receptors, especially inside the liver, don't really have our target, don't really express the somatostatin receptor. And those lesions are prone to receive a below critical amount of radiation that might not be therapeutic to kill those cells and to inhibit future tumor growth. That's one of the major limitations, one of the major potential limitations of current PRRT, that our target is just not there in the lesions that we want to treat. The other limitation is, of course, if we go away from the tumor to the rest of the remaining bodies, above critical radiation dose to healthy organs, especially if we repeat treatment over cycles and cycles. So this is an image of present the lutetium dotatate distribution in the body at 24 hours. And you can see that there's still considerable activity seen by this light gray stain in the circulation, so in the blood pool. This means radiation goes to the bone marrow, to the bone. We have a high uptake of the ligand and radiation in our kidneys, as can be seen here, and we have an intermediate or lower uptake in other healthy organs, such as the liver or the spleen or the bowels. And these radiation doses, they might add up during treatment and they might cause some problems. So in total, how can we improve it? There's a need to improve the tumor to organ uptake ratio that might improve also our clinical outcome for treatment. We might be more efficacious and we might have a safer treatment if we would be able to improve that. What does the first limitation mean? The below critical radiation in neuroendocrine tumor metastasis. There's no question the results of NETA-1 trial have been spectacular. That's a giant step in neuroendocrine tumor treatment. But still, looking closely at the numbers, it means that in the combination treatment of lutetium dotatate and octreotide, after around 15 months, about 30% of patients will have progressed. And of course, it would be nice, by improving PRRT, to also be able to treat those patients effectively. What does the above critical radiation in healthy organs mean? So there's extensive toxicity data available. This has been collected mostly in Europe before publication of the NETA-1 trial, mainly in those 4 trials. And we know that renal failure is not really a huge problem for lutetium-based treatments. It only occurs in 0.3 to 1.5%, so very low numbers, but it can occur with increasing treatments. It can occur with risks to the kidney, like diabetes or previous kidney damage. It has been a huge problem for the yttrium dotatate or dotatok treatment, which is now, of course, not performed that often anymore. On the other hand, serious hematologic toxicity may occur in about 4 to 6% or 5 to 10%, depending on the studies and the numbers, for lutetium or yttrium-based PRRT. And these 2 adverse events might potentially be decreased by improving the radioligand therapy. So what is the current concept? What is one of the concepts in improving PRRT is, instead of using agonists that you can see on the right side, dotatate is an agonist, for example, dotatok is an agonist, you would switch to an antagonist. It shows a slightly different binding. It does not activate the receptor, but it still binds with a high affinity to our target. So how does this work? What is the difference between those 2 concepts? On the left side, you can see the antagonist, neuroendocrine tumor cell, the somatostatin receptor on the surface. And a neuroendocrine tumor cell always has different receptor conformations. So there are activated receptors and deactivated receptors. To put this simpler, if you look at a lock, the lock might be closed or it might be open from the inside. But the antagonist binds to all receptor conformations, no matter how the receptor is activated or not. So the key always fits, whether the lock is open or whether the lock is closed. For the agonist, it's probably different. Key, so if the receptor is in a certain conformation, if the receptor is inactivated, if the lock is closed, then the key is not fitting anymore. This we know from preclinical, also from clinical observation, that the uptake of antagonists is higher as compared to the agonists. And one of these findings, of course, it's all started preclinically. So what you see here is mouse data on the left. You see a PET CT of a mouse that has on the left flank a tumor that carries the somatostatin receptor. On the right flank, a tumor that does not carry this target. And then if we perform a PET CT scan with an antagonist, we can see a nice uptake in our tumor, so we can use it to detect it. In other groups, from Basel have analyzed the uptake over time, and they found out that after 24 hours, by giving an agonist, you have, as compared to the antagonist, a lower radiation dose or a lower uptake in the tumor, so 12 versus 22%. However, the uptake in healthy organs, those 2 critical organ systems, one blood or bone marrow, the other one is the kidney, stays the same between antagonists or agonists. So basically, in this mouse model, it was seen that the tumor uptake decreases while the healthy organs that need to be protected do not receive a higher amount of radiation. And this really triggered clinical trials in this field on analyzing what are the clinical properties of somatostatin receptor antagonists. What can we do with these ligands in terms of imaging, for example? And there's a trial from a site in Basel. This slide is from Nicolas Guillaume, who's a PI of this study, and they compared the gallium dotatok, so fairly similar, it's an agonist scan, fairly similar to the dotatate, the detection rates of this scan intra-individually in patients to an antagonist, which is the gallium OPS 2 or 2. And what they found is that looking at those lesions, the uptake in our lesions, so the tumor to liver ratio, the tumor to pancreas, tumor to intestine ratio, was always higher for the antagonists, so they could kind of confirm the findings from mice, from preclinical experiments. And that also the higher uptake in tumor lesions as compared to our background, our healthy organs, would trigger a higher detection rate. So they could simply, by using an antagonist, they could see more lesions in a patient. What does this mean for therapy? So what clinical data are out there for therapy? There's one small study published, only in 4 patients, that received somatostatin receptor antagonist treatment. Those patients have been progressive under agonist, so dotatate or dotatok treatment, and those patients had kidney insufficiency. And then the department in Freiburg in Germany deemed it acceptable to offer the antagonist treatment to those patients, but they did not just perform the treatment. Before they went into the treatment, they performed a dosimetry. So they gave a below therapeutic amount of both medications and performed a dosimetry to find out for which of the medications, the agonist or the antagonist, is the tumor to organs, a tumor to kidney or tumor to bone marrow uptake higher. And here you can see one patient example and the median results of this patient group of 4. You can see that the agonist, the lutetium dotatate, in a median result showed a lower tumor to kidney ratio and a lower tumor to bone marrow ratio. So 1.6 versus 3.3, 22 versus 56 as compared to the antagonist, which is called here the DOTA JR11. On the left, there is a patient example, one of the patients, where you can see this is really the radiation dose patients receive in gray, and there's a higher radiation dose to those 2 lesions in the pelvis. So those are theoretic data. What does it really mean in terms of treatment outcome for these patients? Again, 4 patients have been treated. The grade of neuroendocrine tumors have been intermediate to high, so grade 3 is already pretty dedifferentiated. Again, all 4 patients had progressive disease, were progressive under prior PRRT, and the 3 months response based on morphologic findings, based on RECIST, based on change of tumor size, indicated that 2 of the patients had a partial response, so roughly to say about the tumor size decreased about 30%. 1 patient had stable disease, so size did not change significantly, and 1 patient had a mixed response. This usually occurs when, for example, the tumor size decreases but a new lesion occurs. After 12 months, the response were still a partial response in 2 patients, so again, the tumor size was smaller than at baseline of therapy. 1 patient had progressive disease, so the tumor size was picking up and was getting higher by more than 20%, and the 1 patient still had stable disease. So again, a fairly small group of patients, but this shows just antagonist treatment can be effective in patients that were progressive to prior PRRT. And triggered by these findings, by these preliminary findings in the small group of patients, prospective studies have been started to evaluate this further. But first, just to summarize on what we know for antagonists, so do somatostatin receptor antagonists have the potential to improve PRRT? They demonstrate a superior or improved binding to the somatostatin receptor of neuroendocrine tumors. Preliminary data in small groups suggest that there's an improved tumor to organ uptake and improved radiation delivery to tumors. Will this really translate into a patient benefit? We don't know yet, so it's just too early to say. But again, it's a future question, so those are 2 trials that will answer the question in the future. 1 trial was recruited in Memorial Sloan Kettering. As far as I learned, all patients have been recruited for the trial. This was a phase 1 trial looking on safety, so what are the adverse events under the antagonist treatment. And the second trial is just about to roll on. It's an international phase 2, phase 3 trial on lutetium PRRT using antagonists, and USA will also be part of this trial, probably with 3 sites. And I just have given you the 2 clinical trials number if you want to inform yourself on the current status of those 2 trials. And finally, thank you very much for your attention.